splits the
What do you mean?
the C where it splits starts with
Oh, the
C.
carina?
Did you want us to like?
You don't have to call that out in the pathway, no. Just know what the structure is. I'll probably tag it on a practical and ask the name, or yeah, I really would only ask the name. Or on a practical, like, or a written exam, ask the structure that if irritated causes spastic coughing or something, then you would tell me it's the carina. So one thing to remember with that pathway is that we do start with a terminal bronchial first, even though the name makes you think it's the end. But terminal bronchial is first, and then after that, go back. Stop it. Oh my God. Where are my pens and stuff? Where'd they go? Okay, cool. Oh, that's why. Because I had it in the wrong. No, I didn't. I don't know why it's being like this, but we're going to fix it. Okay. Here we go. Bless you. There we go. Okay. So just remember that the terminal bronchial is first, and then it goes to the respiratory bronchioles. Once it's inside, once the tubing is inside the actual alveolar sac, then it's called the alveolar duct, and then that reaches to the alveolar sac and then to the individual alveoli. So I'm going to show you on this model, on the microlung model. This would be the terminal bronchiole on top. The ones branching off here to the side and down here, those will all be respiratory bronchioles. And then again, once you get inside the sac, so like here, this tubing here, that would be the alveolar duct. Respiratory bronchioles, and then inside the sac is the alveolar duct.
So once it hits the sac, like right here, this will become
Alveolar duct.
Mm-hmm.
Okay, so next key concept is that volume changes can cause pressure changes, which cause air to move. So air moves from areas of high pressure to areas of low pressure. Just like we talked about, like diffusion and things moving down its concentration gradient, it works the same way with pressure. So air likes to move from areas of high pressure to areas of low pressure. So air moves into your lungs when the pressure inside the lungs is less than the atmospheric pressure. So when there's more pressure outside, less pressure in your lungs, and air is able to move in towards that lower pressure. So how is this accomplished? What is the name that we give to bringing air into our lungs? Yeah, so inhalation or inspiration, either one of those is fine. And then the opposite is true for exhalation. Air moves out of the lungs when pressure inside the lungs is greater than the atmospheric pressure. So when the lower pressure is outside the body, then air is able to escape and move out. So how is this accomplished? Through exhalation or expiration. Either one of those terms works. For that idea, I want you guys to really quickly move forward in your notes to the bottom of page 23 where it talks about Boyle's law. I'm going to talk about that really quickly and then talk about lung pressures. So movement of gases follows something called Boyle's law. The Boyle's law tells us that volume and pressure are inversely related, meaning that high volume means low pressure, low volume means high pressure. They are inversely related. When we see an increase in volume, we'll see a decrease in pressure. When we see a decrease in volume, we'll see an increase in pressure. You may have heard in a chemistry class doing equations like P1 V1 is equal to P2 V2. It's that concept, but we're not getting into math in this class, so you don't have to worry about that. But during inhalation, your thoracic cavity volume increases, intrapulmonary pressure decreases, and air flows into the lungs. So what happens when you take a deep breath in, and it doesn't seem this way. It doesn't seem like your chest gets set up before the air moves in. It seems like it's happening all at the same time, but actually your chest cavity moves before the air moves. So what happens is, here is your chest cavity. If you guys remember from B32, your diaphragm is like this, is a dome shape when it's relaxed. Right? So this is what the diaphragm looks like when it's relaxed. So before you breathe in, what you end up doing is contracting that diaphragm. Go back. It's contracting that diaphragm and going to a more open container. So this is how much space you had for air before inside your chest when the diaphragm was relaxed. And then when we have it contracted down here, now you have so much more room for air. Okay, so you open up the volume, which is going to decrease the pressure inside. How it decreases the pressure inside is if you look at this little container here. When you have a lower pressure, you'll notice all these little air molecules are very close to each other, bouncing off the walls and bouncing off each other at a very fast rate. That is going to create high pressure. Okay? When your diaphragm contracts and you create more space inside your chest, then you move to a space like this, where there's more room for those air molecules to move. They're bumping into the walls and each other less often, which means less pressure. Okay, so when you open up your chest, when you contract your diaphragm and you bring your rib cage out, you're creating more volume, which decreases the pressure, and now the pressure inside your chest is lower than the pressure outside, and air is able to move in. Any questions about that? You're making a bigger space for those air molecules to move around, so it's less pressure. That pressure drops and air is allowed to move in.
So when you breathe in, that's when it makes the bigger space?
Yes, yes. And
Pressure increases when we breathe out?
yes, so when you breathe out, you're bringing everything back down and in. So go ahead, before we move to out, go ahead, Corey.
Contraction factor is happening before
The air.
flows in.
Yes. It's kind of a gradual thing. So as it's making more space, the air is moving in but you're moving that space before the air actually moves. Which is crazy to think about. It's just happening so fast that it all feels like it's happening at the same time. But as you're creating more space, that air can gradually move in as you're breathing in. So then when we go to exhalation, what's going on there is you're going from having that nice open space that you had before during inhalation. You go from this much room to then a now relaxed diaphragm with much less room, which is going to have a higher pressure. Not only from relaxing the diaphragm, but once you breathe out, you're now bringing your rib cage back in and down. Okay, because when you breathe in, you open up your chest, make all this room, less pressure, and air is able to move in. But when you exhale, you're making everything small again. You're creating less volume, which means that the air molecules are going to be bumping into each other more often, creating more pressure. That's going to make the pressure inside your chest and inside your lungs greater than the atmospheric pressure, and then air is able to escape. Yeah. Any questions on that concept? Yeah.
The relaxing stage of the diaphragm is like this, right?
Yes, relaxed is a dome shape. Yeah.
And if a person dies, do they have like a dome shape thing?
Well, when they die, you run out of ATP, so most likely it'll die in a contracted state with that rigor mortis until everything starts to break down. Because remember, you need ATP to relax the muscles. They stay contracted otherwise.
Our diaphragm contracts when we breathe in.
Yes.
And relaxes when we breathe out.
Yes. Yep. And yeah. Well, let's go Corbin, then Catherine.
So, is that like what people say breathing from the diaphragm? It's like, like in choir, they say
Oh well, yeah, because that's supposed to like help you project your voice more too. I played the oboe when I was little, and they would tell me that I would need to like cause vibrations from my belly. That was always very hard to do. Does it just creates easier breath work? But I mean that's more technique than, yeah.
You know, like when children are having like trouble breathing, or anyone, they'll like breathe from their stomach almost.
Uh huh.
Like you see more movement in the stomach than like in the chest.
I guess when they're forcefully doing it. Yeah, I mean, yeah. And because remember, your diaphragm's a skeletal muscle, so even though it has some autonomic control, you have control over it too. So when you're actually making your diaphragm move, yeah, it's gonna make your abdomen move more forcefully.
Oh, okay, so if someone's like struggling to breathe, it's the diaphragm is working harder to.
Yeah.
Okay. Can it tire out as well? Like,
Yeah, just like anything else. Yeah. So any questions about that pressure relationship? Oh yeah, sorry, Catherine.
So you contract the diaphragm, you breathe in, there's more volume, which decreases the pressure temporarily until the air comes in fully.
Yeah, so you are contracting your diaphragm, right, and creating more space, less pressure. Okay, as you're doing that, it doesn't just collapse like automatically. It's a gradual thing of it creating more space. So as that's happening, you're lowering the pressure. As you're lowering the pressure, more and more air is able to move in until you take that full breath. And then the opposite is the same. As you are relaxing that diaphragm, it's slowly going up and creating more pressure, and air is able to move out. Yes, Corbin. No, you're fine.
Just, would there be like any way to think of this? I know it's not the same thing, but I'm kind of viewing this as like one big, like, vasodilation. So like when it increases, that would like lower the pressure.
Yeah, I mean, yes, anytime you create more space, you're decreasing the pressure, just like with vasodilation. Yeah.
Okay.
Yeah. Yeah. It's the same concept. The same concept of volume and pressure works here. Yeah. We just didn't give it a name when we talked about it with blood vessels, but the pressure volume relationship is called Boyle's Law. Okay, any questions on that? Okay. Everyone good?
So whenever you exhale, there's like less room.
When you exhale, you're making your chest smaller, which builds up the pressure so that the air can escape. Because it is only going to move in response to changes in pressure. So when the chest pressure is greater than the pressure outside, then the air can follow the lower pressure. All right, so now we're going to talk about pressure relationships in the thoracic cavity. So step 1, and you have like a whole blank space in your lecture notes to write this down. So make sure you have, this is how much room I take up. So just make sure you make enough room to write some stuff down. But step 1 is that the pressure, so PATM means atmospheric pressure. Your atmospheric pressure at sea level is equal to 760 millimeters of mercury. That is your atmospheric pressure. That is the pressure of the air around you. However, it's really hard to add and subtract numbers, or harder to add and subtract numbers to and from 760 than it is to 0. So what we do when we're talking about pressures of the thoracic cavity and pressures of the respiratory system, we actually set 760 as our base. So we actually set this to 0, which makes the math a lot easier. So know that respiratory pressures are always described as relative to atmospheric pressure. So we're always comparing to atmospheric pressure, always comparing to that 760. So we're always going above and below that 760 in order to allow air to move in or out of the lungs. So when we say we're at a negative respiratory pressure, we just mean that we're lower than atmospheric pressure. If we say we're at a positive respiratory pressure, it's always going to be relative to atmospheric pressure, so that just means that we're above that atmospheric pressure because we're setting that atmospheric pressure to 0. And if we're at 0 respiratory pressure, that just means that our respiratory pressure is equal to that atmospheric pressure. So we're always talking in relation to or comparing to atmospheric pressure. Questions so far? Okay. So step 2 is inhalation. So I already kind of explained how this works, but pressure decreases via a flattened diaphragm or you can say contracted diaphragm, either one. And pulling out the rib cage. This creating more space in the chest cavity and decreasing pressure, this causes a negative, This causes a negative pulmonary pressure. And we call that P-pull. I'll show you where that is, right here. P-pull is intrapulmonary pressure, the pressure inside your lungs. So again, for inhalation, you're contracting your diaphragm, you're pulling your rib cage out. This decreases the pressure. And since we're comparing our pressure to atmospheric pressure, you now have a negative intrapulmonary pressure. That just means that the pressure inside your lungs is less than atmospheric pressure. That allows air to move in. So this creates a negative P-pull. And air is sucked in. Questions about that change in pressure during inhalation? Yeah.
So it's not necessarily like the diaphragm that's
Doing.
causing the air to go in and out, it's more the pressure.
Yes. The diaphragm and the rib cage open up the space, which decreases the pressure, and that allows air to move. Because air is going to move in response to changes in pressure.
Is it kind of like a straw? You know, like it's not really you sucking on the straw that's causing it to go up, it's more like the change in pressures.
Yeah, because you're pulling, yeah. Can I erase the right side of the board to do exhalation? Okay. Yes.
I guess it's confusing because in my head I'm like, well, I'm inhaling air, so that's what's like opening up the lungs, I guess. But
It's because you can't really feel what's happening and in what order, because again, it feels, when you breathe in, it feels like it's happening all at the same time, but I promise you, I promise you that the diaphragm is moving first. It's a split second sooner. Yeah. But it's air will not move unless it's moving in response to pressure. There has to be something driving that air in one way or another. And the only way that air is allowed to move in is when that drop in pressure happens because of the opening of the space. Now,
inhale or exhale at first, that's like your diaphragm either contracting or
relaxing, yeah.
relaxing, and then the air moves in
Mm-hmm.
because of the pressure.
Yep. So you create the space, which changes the pressure, and then air follows. But it's happening right after another. So it's hard to catch the differences in the timing of those movements.
Professor, would it be safe to say that it's like a vacuum?
It's like a vacuum.
Like you're creating a vacuum.
Yes, and with those changes in pressure, then air is able to be sucked in. Yeah. So for exhalation, pressure increases via upward movement, or you can say relaxation of the diaphragm. And pushing inward of the rib cage. So we're making everything smaller. The diaphragm relaxes and goes back to its dome shape. The rib cage is pushed downward and inward. And this is going to increase pressure, which causes a positive intrapulmonary pressure, or P-pool. So the pressure inside your lungs is now greater than the atmospheric pressure, which this allows us to push air out of our lungs. So we have to make the space smaller, which increases the pressure, and now the pressure inside your chest is greater than the pressure on the outside, so then air is able to move out. Any questions on inhalation or exhalation? And I can erase everything on the left side? Okay. This is the last thing on this concept. We also have something called intrapleural pressure. This is called PIP. And this is essentially the pressure inside your pleural cavity. So in between your visceral and parietal pleura, that space in between is also going to have a different pressure as well, called the intrapleural pressure. Now your intrapleural pressure, or the pressure inside the sac outside the lungs, this is always about 4 millimeters of mercury less than your pee pool or the pressure inside your lungs. So the pressure in your pleura or your pleural sac or pleural cavity, that's always slightly lower than the pressure inside your lungs. So PIP is always negative relative to the pressure inside your lungs, which is pee pool. And this prevents lung collapse. Remember we talked about cardiac tamponade, and if there's enough fluid outside the heart, it causes an opposing pressure outside the heart, and then the heart can't contract the way that it's supposed to. This is kind of a similar concept. The pressure in the pleural sac outside the lungs has to always be less than the pressure inside the lungs, because we don't want an opposing pressure on the outside of the lungs, or else it won't be able to inflate and go back to its original shape the way that it should if we have a large pressure on the outside. So that intrapleural pressure always has to be slightly lower than the pressure inside the lungs, or else you'll have problems with inflating and deflating the lungs. Does that make sense to everyone? Okay. Yeah.
In the, it's talking about the pleural cavity.
Pleural cavity. So in between the visceral and the parietal layers,
Okay.
in that very small space.
So there might be cavity like around the lungs, between the parietal and visceral.
Yes, it's in between the parietal and visceral, because it's like a continuous double membrane. So it's just the pressure inside there, which is not much, because there's not much space in there. But we always have to make sure it's less than the pressure inside the lungs, so that we're not causing a pressure from the outside. Yeah.
So is it changing too, but it's always just 4 different
Yes.
from what it is?
Yes. So Catherine asked if it's always changing with the pressure in the lungs. It is. So as the pressure inside the lungs is getting lower, well then that PIP is also getting lower, and it's always just going to be 4 less than what's inside the lungs at all times. Okay, so it's like I'm not a physics major, so it's hard to make that kind of stuff make sense. But it's constantly with the lungs and always pulling on the lungs with the lungs. So it's always just moving with that same pressure differences, but just 4 less than what we see inside the lungs at all times.
Is it kind of like a gravity kind of thing? Like
Yeah.
It is a collapse.
Exactly. So if you've ever like had a baggie, right, and you put like a very small bit of water inside of it, the walls of that baggie are going to always stick together. You can't pull them apart. So it's kind of the same idea here with the pleural cavity, or the pleural membrane can never come completely apart from the lung. So it's always with it, no matter when it's inflating or deflating. So it's always staying like a consistent pressure along with the lungs. That's the best I can do as a non-physics major. So a collapsed lung can happen when those pressure differences go out of whack, and we'll talk about that. The correct term for a collapsed lung is called atelectasis. So you need to make sure that's what you call it going forward. Collapsed lung is atelectasis. A couple reasons why a collapsed lung may occur. One is if a bronchiole becomes plugged and air isn't allowed to move in and out of the lungs. And this can be caused by something like pneumonia. Pneumonia can cause the bronchioles to become plugged up. And what essentially happens when a bronchiole becomes plugged with mucus or some other fluid due to an infection, what happens is that the alveoli absorb all the air and they themselves collapse and the entire lung collapses. Because your alveoli are constantly inflating with air and deflating all day long. But if something happens where there's no longer airflow, whatever air that's left, those alveoli are going to suck up whatever air is left. And there's no new air coming in. So those air sacs will one by one all close, which is then going to make the entire lung collapse as well. Just because they're absorbing all the air that's left, there's no new air coming in, and the entire structure collapses. Does that make sense, everyone? Okay. Another reason is due to something called a pneumothorax. And so a pneumothorax, just spell that really quickly and I'll show you the diagram next. Oh, it's on the next page. Here, pneumothorax, in case you haven't spelled it yet. But rupturing either the parietal or the visceral pleura can cause a pneumothorax. So this can happen because you get some kind of trauma to your chest, like if you got stabbed in the chest. Not that that's like super common, but it could be from something like plunging into you from a car accident or something like that. But if you have a piercing wound to your chest that breaks that pleural membrane, then what's going to happen is that air and fluid are going to be now entering into that pleural cavity. And what ends up happening is that pressure, that intrapleural pressure, is no longer at a -4. Because now you've introduced air, you've introduced probably some blood as well. And so as soon as these two pressures equalize, that lung's going to collapse. There is no difference in pressure to allow the lungs to inflate and deflate anymore. So as soon as they equalize, the lung is going to collapse. Unfortunately, the visceral pleura can also spontaneously rupture. So not to give you unlock a new fear of yours. It's really rare. Does not happen often at all. I would have to look up the rate of it, but it's very rare. But it can spontaneously happen that your visceral pleura could rupture. But the same thing, if you end up having an equalizing in pressure where there's no longer a lower pressure outside of the lungs, it's going to collapse. So any questions on that? You unlock a bunch of new fears in this class, but know that that's super, super rare.
I'm pretty sure I was like in high school, but I had pneumonia before. It was the most painful thing ever.
Oh, yeah.
You feel it in your back, like you can't sleep, can't sit down, can't stand up, it hurts.
Mm-hmm.
You do feel it.
That's why a lot of people who are immunocompromised, whether it's due to something like AIDS or cancer or what have you, they can die from pneumonia for sure. All right, let's take a 10-minute break, come back at 9:42, and then we'll finish this lecture. Alexia brought up something I forgot to tell you guys, but for a pneumothorax, the treatment for that would be a chest tube to draw out whatever excess air or fluid was built up due to that rupture.
Is that like on like the shows or movies when you see people like stabbed?
With the chest tube, yeah.
It's all dramatic.
Yes. So the treatment would be a chest tube. Ooh. To draw out air or fluid.
So a pneumothorax is just another type of collapsed lung.
No, a pneumothorax would be the cause of a collapsed lung, yes. And then the pneumonia that causes a plugged up bronchiole, that would be a cause of a collapsed lung or atelectasis, yeah.
I feel like since pneumothorax, it seems like a
Yeah. So it is a condition, but it's more like an event that then causes the collapsed lung. Okay, so pulmonary ventilation is the scientific term for breathing. And for inspiration, it's all we've already talked about, but it's kind of giving you like an in steps in order. The diaphragm contracts and flattens. The muscles lift the rib cage upward and outward. This causes the chest cavity and lung volume to increase, which is then going to cause the pulmonary pressure to be less than the atmospheric pressure. So this moving of the diaphragm and the lifting of the rib cage upward and outward, this makes more volume and less pressure, causing a negative intrapulmonary pressure. So now the intrapulmonary pressure is less than atmospheric pressure, which then causes the air to rush in. Anybody remember the muscles we find in between the ribs? They're intercostals. So the ones that are going to be lifting the rib cage upward and outward are going to be the external intercostals. So everyone okay with that concept? You're setting up the stage first to cause the change in pressure, and then the air follows in response to that change in pressure. They're showing you the same thing and just kind of showing you the movements of the muscle and ribs. For expiration, which is the opposite, the diaphragm is then going to relax. The muscles, which are still the external intercostals, but now they're going to be relaxing to bring the rib cage downward and inward. This causes the chest cavity and lung volume to decrease, which is now going to cause that intrapulmonary pressure to be greater than the atmospheric pressure. So now we cause a positive intrapulmonary pressure, one that's greater than atmospheric pressure. And then the air rushes out. So any questions on that? Okay. So your skeletal muscles of your quiet breathing, so the breathing that you do at rest, okay, is going to be your diaphragm and those external intercostals. Their contraction and relaxation leads to inhalation and exhalation, or inspiration and expiration, respectively. Now, you do have something called forced inhalation, where you can take a really big deep breath in if you needed to, or like what Corbin's doing right now with yawning. The muscles of forced inhalation allow for deeper inspiration by increasing thoracic cavity expansion when they contract. So this includes your sternocleidomastoid along your neck, your pectoralis minor at your chest, and some other accessory muscles. But those will be the muscles of your forced inhalation. These are extra muscles you have to recruit if you want to take a bigger deep breath in. The muscles of your forced exhalation contract during hard exhalation, so like when you're coughing or you're like blowing out the birthday candles, things like that, and they work to decrease your thoracic volume. So this is going to include your internal intercostals, your abdominal muscles, and then some other accessory muscles as well. So we have quiet breathing, forced inhalation, and also forced exhalation, which are all going to require different muscles. Okay, any questions on that?
Do you mind if I borrow a pencil?
No, go ahead. Yeah. All right, so some physical factors that influence ventilation or breathing. One is your bronchial diameter, and that can change in response to irritants and allergies. So I'm going to make some notes. And I'll show you an image about asthma, but I want to make some notes first. So bronchial diameter is one way to influence ventilation. So one way is through irritants and allergies. So, and I think this is already in your lecture notes. But irritants and allergies can activate a parasympathetic reflex. Is this already in your lecture notes? Yeah. Okay, so this causes aggressive contraction and constriction of bronchioles, reducing airflow. So when you become irritated with something, or your respiratory tract is, or if you're allergic to something, this is going to cause all of your airways to constrict, because we don't want that thing to come in. And so then airways constrict and reduce airflow. This can definitely happen during asthma, especially allergic asthma. Is it is the most common form of asthma you can have, is allergic asthma. And with that, when you have an asthma attack, histamine and other chemicals can cause strong bronchoconstriction on top of that can almost completely stop ventilation. When you have asthma, and actually I guess I didn't have to write this down because all that's already in your lecture notes, right? About the asthma attack and everything? Okay. So one thing about asthma, oh, it doesn't have it there. I used to have those there. Well, I guess I'll just tell you. With asthma, because we're talking about it more in respiratory too, people with asthma already have constricted airways. Like, that's already their baseline, is having constricted airways. And so as soon as they have an allergen, or an irritant exposure, that's going to cause their airways to then constrict even further. Okay, and if they're having chronic asthma attacks over long periods of time, they're also creating lots of inflammation and lots of mucus buildup, which is going to make their airways constricted even more and having airflow even harder to pass through with the constricted airways, the inflammation, and the excess mucus. And so this can be really dangerous for those with asthma, with allergic asthma or any kind of asthma in general. And so what they can take is epinephrine. So they can have an EpiPen that, when injected, will cause their airways to then dilate to allow for restoration of that breathing.
When you're talking about airways, like dilating, is that the bronchial?
The bronchioles, yeah.
So it's not the alveoli that's like...
No, it's going to be the airways leading up to them, yeah.
Okay.
Mm-hmm.
And then what does albuterol do for asthma? Does it just...
Albuterol is also going to open up the airways. So we'll talk about that when we get to the end of respiratory too. We'll talk about the different breathing testing that's done and how albuterol can actually be used to diagnose people with asthma. Yeah.
The EpiPen, where do you use it? Does it matter?
You just intramuscularly. Yeah. What'd you say?
I was gonna say like your thigh muscle. Like,
Yeah, thigh. Yeah, some usually that's the easiest. It's an intramuscular injection.
If you were using it in the heart with...
That's I wouldn't recommend. No. But you should be able to get it into your muscle. It'll flow eventually to your lungs and then open up those airways. It moves very fast. It happens very fast.
So, Professor, when
Yes.
you said that there's also like mucus buildup, would that affect like the respiratory membrane? Would that
Yes, for sure. It makes it harder for air to move across. And we'll talk about that eventually at some point. I know there's some point where we talk about that, about mucus buildup in the airways.
If someone's sick and they have asthma, it's going to make their asthma worse because it's just getting more and more like...
Yeah, you get the more fluid buildup, the thicker your respiratory membrane is, and the harder it is to exchange gases across it. So that's bronchial diameter. Alveolar surface tension. So we have what are called type 2 alveolar cells that make surfactant. And you guys already hear about this in your, yes, okay. So type 2 alveolar cells secrete surfactant. And they do this to prevent alveoli collapse. Do you guys know what type 1 alveolar cells are involved in? So I'll just tell you, just so you know the difference. Type 2 is to secrete surfactant. Type 1 is involved in gas exchange. So those are going to be the cells of the respiratory membrane that are allowing for the movement of air to go across. So type 2 alveolar cells secrete surfactant to prevent lung collapse. There is a condition called IRDS, stands for infant respiratory distress syndrome. And this is caused by, this is experienced by premature babies that are not producing enough of that surfactant yet because their respiratory system is not developed enough yet. So this is due to premature babies not producing enough surfactant. What was the question?
Isn't the lungs the last thing to develop in the world?
Say it again.
The lungs, aren't they the
Last, yeah, one of the last things to develop, yeah. So with the premature babies, they may have not had that last bit of development that's needed. So one way to help treat that urge, because they're at risk of their alveoli collapsing if they don't have enough surfactant to keep them nice and open. Because that, so let's say this is an air sac here. The surfactant lines the air sac and keeps it so that the water and the air sacs are not as attracted to each other, so they won't collapse when they're inflating and deflating. So if the premature babies are not producing enough of that surfactant to line the air sacs, then those water molecules may be more attracted to each other and may cause a collapse when they deflate. Okay. So one way to treat that is through surfactant sprays. So they literally will just spray surfactant down their respiratory tract. And this can either be a natural surfactant spray. So for naturally occurring, they were able to extract from cells, or from, well, the natural will be from animal sources, like from, if we get it from, I don't know what animals we get them from, but it can either be natural or it can be synthetic. But we can give them surfactant sprays to spray down their respiratory tract to help keep their air sacs nice and open. Or we can give them antenatal, which means after birth, corticosteroids. And the steroids are to speed up development. So to hopefully have their respiratory system develop quickly enough to then start producing that surfactant on their own. There is an adult version of this called ARDS. So it's the same thing except adult respiratory distress syndrome. And this is usually caused by near drownings. So if they were to inhale around 2 to 3 ounces of water or more, then they can experience ARDS. Or lots of firefighters experience ARDS because of the smoke inhalation and smoke damage. So ARDS is essentially just gas exchange problems.
Do you get it with monoxide poisoning too? Or is that something like that?
I mean, I don't know if they would consider that under ARDS. Maybe I'd have to look that up. But we usually talk about carbon monoxide poisoning separate from ARDS.
So would this just be like a thickening of the respiratory membrane then? 'Cause
Yeah,
water-
with the soot and extra water. Yeah.
Okay. Would smokers also get this?
Say it again.
Smokers?
Yes, I mean eventually, yeah. Yeah.
Is this the same
But-
thing as, what is it called? A lot of people have it. I can't think, they always need oxygen, like constant O2 months.
What is it?
So COPD. Is
It's different.
It's different?
It's different. It's caused by different things. So these are usually because of events that caused the ARDS to develop, versus like COPD is because of like a smoking habit or pollution or just like overtime damage versus like a one shot bad thing happened.
I see. So this is
causing
like a
distress.
trauma.
Mm-hmm.
Okay.
Professor?
Yes.
So, speaking of like the arts, there's like shells that you can file down,
Mm-hmm.
but the dust ends up getting into your lungs, so they wear like masks.
Mm-hmm.
And I've heard that it like causes
It could be. I'd have to look into it if it'd be categorized underneath the same thing. But yeah, it may be.
Would it work the same way, kind of like how like soot?
I would have to know what the shells are and what they're the material is. But
Because like when you like file it, it's like dusty.
yeah, I would assume it's probably going to be a similar thing. Yeah.
Is ours also treated with like surfactant?
No, because not the same problem. Because ERDS is a lack of surfactant. With ARDS, it has to do with affecting the respiratory membrane, but not in the same way. You're causing either like water to be there with that near drowning, or like soot or smoke inhalation to cover that membrane. So it'd be a different cause, so a different
Is this, like,
treatment.
temporary?
Usually it's temporary. Depends on how bad it is. If it's going to cause like long-standing problems.
Okay,
Yeah.
so this is more like a temporary from like trauma. And
Yes.
COPD is more like a terminal. Like,
Yeah, the chronic thing.
chronic,
Yeah.
Okay.
The last physical factor to influence ventilation is something called compliance. Compliance is essentially the stretchiness of lungs. And so the more compliance you have, means you have easy lung expansion. And so your compliance is determined by something called the stroma. So we talked about stroma for your lymphatic system. Stroma is just any non-living supportive network of an organ. And so your lungs also have a stroma. And the job of this stroma is to make elastic fibers. And the more elastic fiber you have, the more compliance you have, and the easier it is for your lungs to expand and recoil. So your compliance will lessen with ossified cartilage. So if your cartilage begins to be ossified or start to harden, and this is common with old age. Or you can lessen your compliance or your stretchiness of the lungs through fibrosis. And this can be through exposure to toxins. We live in a wonderful area for that. Radiation can cause fibrosis or chemotherapy. Certain medications can cause fibrosis of the lungs. The kind of medications are those that treat your heart. Heart medications can cause fibrosis. Certain antibiotics can cause fibrosis. And anti-inflammatories. And then also, you may just be more genetically inclined to have fibrosis in your lungs.
Is fibrosis the one they need like the vibrating, the constant like auscultations through the back?
Oh, like with cystic fibrosis?
Cystic fibrosis.
Yeah, we'll talk about that too. You'll have a critical thinking assignment on it. All right, so any questions about compliance or stroma? Okay.
So can your stroma increase and decrease, or does it kind of just stay the same?
It'll stay the same and then it'll decrease
So
over time, yeah.
Obviously, this has to be somewhat interesting to me to like teach it for a living. But if you're like interested in watching an hour-long video, there's this video on YouTube that I'll send to you, and it's so interesting with like this guy in I don't know what country, but it's one of the Asian countries, and he got exposed to like a lot of radioactive like radiation.
Mm-hmm. send it to me.
I'll send it to you. It's really interesting.
Okay. Or you should post it on the Discord in the SU.
This
Yeah.
guy like goes through. I love watching him. He like just articulates things so well. And like he's funny.
Yeah.
I'll send it.
Okay. Yeah, Catherine.
There's someone also like cartilage.
Just your so the cartilage of your like of your rib cage. So like your coastal cartilage, they can harden over time, which is going to make it hard for you to then move your ribs as your lungs are expanding.
So it's not on the lungs.
It's not on what?
It's nothing on the lungs.
The lungs itself? No, it's just the container in which the lungs are allowed to move. Yeah.
Is the trachea out of cartilage or no?
Yeah, your trachea is made up of C rings of hyaline cartilage. Yeah. All right, the last thing we're going to talk about is partial pressure. And then the part on respiratory volumes, we're going to save that for Wednesday. But partial pressure, so it's a little bit of math, but it's not too bad. So first of all, we have something called Dalton's Law. And Dalton's Law just states that total pressure equals the sum of pressures from individual gases. And I think this is already in your lecture notes. Let me see where that is. Respiratory volumes. Yeah, so skip respiratory volumes on page 25, go down to Dalton's Law of Pressure on page 26. We'll finish here and we'll catch up with respiratory volumes next time. But Dalton's Law just says that the total pressure in the atmosphere equals the sum of the pressures from the individual gases. And so these are all of our partial pressures here in the atmosphere at sea level. And so all of those pressures equal to our 760 millimeters of mercury, which is our atmospheric pressure. So 78.6% of the gases in our atmosphere come from nitrogen. 20% of our atmospheric pressure comes from oxygen. 0.04% comes from CO2, and 0.46 comes from water that's in the air. And so, again, these are our partial pressures over here. And these partial pressures make up our total atmospheric pressure. And so, again, atmospheric pressure is equal to 760 millimeters of mercury. And so what we do in order to calculate these partial pressures, so let's start with nitrogen. Nitrogen is 78.6% of our atmospheric pressure. To figure out what the actual pressure is, I know it tells us 597, but we should be able to calculate that ourselves. So what you do is you divide by 100. You make this into a decimal, which is going to equal 0.786 when you divide by 100. So this is equal to 0.786 in decimal form. We multiply that by our total, which is 760 millimeters of mercury. And if you multiply those two together, you should get 597 or something very close to it. 0.786 times 760, 597.36, which we can round down to 597.
So what is this 78.6% again?
That's how much our atmosphere is made up of nitrogen. So we talked about like honk before, how the gases that are in our atmosphere. So 78% of what we breathe in is actually nitrogen. 78.6. Now I'm showing you these now so that we can figure out how to calculate partial pressures. But for the purposes of this class and for respiratory system, we're only going to be really focusing on O2 and CO2. But you should be able to know how to calculate a partial pressure. So this is for nitrogen. We'll try oxygen as well. Oxygen is 20.9% of our atmospheric pressure. If we make that into a decimal, move the decimal place over 2 times to the left, it ends up being 0.209. And if we multiply that by our total atmospheric pressure, that means of that 760, oxygen makes up 0.209 times 760, makes up about 159. It's 158.84, but we can round that up to 159. So of that 760, oxygen makes up 159 of that 760. And then if we do CO2, CO2 is 0.04%. We still have to move that decimal place over 2 places to the left. So what you end up with in decimal point or decimal form is 0.0004. Multiply that by 760. And that just means that of that 760, CO2 only makes up 0004. Only makes up 0.3 millimeters of mercury. So if I asked you on an exam to calculate partial pressure, would you be able to do it? If I gave you the percentage and you know that it's 760 millimeters of mercury of our total pressure, could you figure out the partial pressure? Okay.
So we don't have to memorize the
You don't have to memorize the percentages, no. Oh, well, the 159 is going to round up to 160, and the CO2 0.3. Those are 2 numbers you're going to have to know. The partial pressures for our CO2 and oxygen in the atmosphere, but I'll bring it up here soon. The percentages, though, no. You don't have to memorize the percentages. Okay. Everyone okay with partial pressures? Okay. So your metabolic nitrogen in our body and our water is actually ingested and not exchanged at the respiratory membrane. So that's why when we talk about the respiratory system, we don't talk about nitrogen and we don't talk about water, because we ingest that through our foods and through water that we drink. And so we don't exchange that at our respiratory system. So we only talk about oxygen, CO2, not nitrogen and water. Yeah.
So, but those still have a component to the pressure?
Yeah, so they're still in the air that we breathe. It's just that when we breathe in that air, that's not what we're using. We're not using the water. We're not using the nitrogen. We're only using the oxygen and CO2.
Oh, okay.
Yeah. Does that make sense?
Yeah.
Okay.
That's why we focus on those two.
Down those 2, yeah. All right, so I'm going to do a quick run through of this diagram, which is probably going to haunt your dreams over the next few weeks. So we'll talk about it now, then we'll talk about it again when we come back on Wednesday. And this is going to be a big, big part of your next exam. So let's get ready to talk about it. But again, this is just a quick review of it, but we're going to go over it again and again when I see you again on Wednesday. So these are numbers you do have to memorize. You have to memorize this entire chart. But your inspired air, and does this zoom in when I zoom in? So your inspired air, so the air that you breathe in from the atmosphere, we just calculated it over here, the 159, it's just rounded to 160. But of the air that you bring in from the atmosphere, the partial pressure of oxygen in that air is 160 millimeters of mercury. The partial pressure of CO2 in the atmosphere that you bring in is 0.3 millimeters of mercury. And I'm okay if you round this 0.3 to be about 0 millimeters of mercury. I'm okay with that. Whichever one is easier for you to memorize. Okay. Is everyone okay with that? All right. So then the alveoli of your lungs, okay, already has So when we bring in the new air and we mix it with the old air that's already in your lungs, what you end up having is a partial pressure of oxygen of 104 millimeters of mercury and a partial pressure of CO2 of 40. Because again, what you bring in from the atmosphere is not going to stay that 160 and 0.3, because this new air that's coming in is mixing with the old air that was already in your lungs. So with this exchange here, we have mixing of old and new air, and this is what ends up being the result of that. Now, after we've mixed up the old air and the new air, now our new partial pressures is PO2 of 104 and a PCO2 of 40. All right. Now, when that air inside your lungs, which is going to be inside these air sacs, when the air inside those lungs exchange with the blood or the capillaries around your lungs, we're going to have new partial pressures. Now we're talking about the partial pressures in the blood. So we're bringing air from the atmosphere, from inside your lungs. We're exchanging that with the pulmonary capillaries at the lungs as well. And now we're going to talk about partial pressures of oxygen and CO2 in the blood. Okay? So after we oxygenate the blood, what are the partial pressures that we're delivering to the body? So what we end up with, after having a PO2 of 104 and a PCO2 of 40 inside the lungs, when we exchange those gases with the blood inside the pulmonary capillaries, what we end up having is a PO2 in the blood of 100 and a PCO2 of 40 in the blood. And the reason why it doesn't stay 104 like it was in the lungs and we kind of come down to 100, this is due to insufficient diffusion. So diffusion is not perfect, and we're not going to get exactly what's inside the lungs, inside the blood. We're going to get close to it, and there's going to be an equalization that happens, but then we're going to have a slight drop. So PO2 ends up being 100, and PCO2 ends up being 40. And so that is in all oxygenated blood. Okay, so this exchanging of gases that happened here was here at the lungs. So now, in the pulmonary veins coming out of the lungs towards the heart, it's going to have a PO2 of 100 and a PCO2 of 40. As we go through the heart, on the left side, we go to the left atrium, down the left ventricle, out the aorta, and then out to the body. During that time, have we exchanged gases again? Coming from the pulmonary veins to the systemic arteries? No. All we did was leave the lungs, go through the heart, and come out the aorta. No gas exchange has happened. And so both in the pulmonary veins and in the systemic arteries, these partial pressures are going to be the same. So anytime we see oxygenated blood, it's going to have a PO2 of 100 and a PCO2 of 40. That is for all oxygenated blood of an average, normal, healthy person. Their oxygenated blood should have a PO2 of 100 and a PCO2 of 40. Now, when we get to the tissues and our cells are where we're using all of that oxygen that we've received from the blood. So after activity, our tissues end up having a PO2 of 40 or less than 40, depending on how much activity we're doing, but the baseline is 40. Your tissues will have a PO2 of 40. And again, if you're doing some kind of strenuous activity, it'll be less than 40 because you'll be using up more oxygen. And your PCO2 is going to be greater than 45. So it's about 45 at rest, but again, if you're doing some kind of strenuous activity, you're going to be building up even more CO2, so CO2 can be greater than 45. So now, in the oxygenated blood, its PO2 is 100 and PCO2 is 40 millimeters of mercury. at your tissues, where we're going to exchange oxygen and nutrients right now at the tissue level. We have this oxygenated blood. We're going to deliver that oxygen to all of our organs, right? So at the tissues, PO2 is less than or equal to 40 millimeters of mercury. It depends on how much activity we're doing. And our PCO2 is greater than or equal to 45 millimeters of mercury. Now, we already learned a bunch in this lecture that air always wants to follow the lower pressure, right? So if we have a PO2 of 100 at the blood and a PO2 of 40 at the tissues, which way is that oxygen going to want to move? Towards the blood or towards the tissues? Towards the tissues where the lower pressure is. So then this oxygen from the blood is then now going to be, if this will stop moving, is now going to be now delivered to the tissues. This is how we deliver oxygen and nutrients to our tissues, because there's this difference in pressure that allows that oxygen to move towards the tissues. If we're at 100 in the blood and only at 40 in the tissues, that tissue needs that oxygen. And so the oxygen is going to go towards where the need is. Does that make sense? Now, our PCO2 in our oxygenated blood is 40, but our PCO2 where we're doing activity and building up waste is 45 at the tissues. So which way is that CO2 going to want to move? Towards the blood or towards the tissues? Towards the blood where the lower pressure is. And eventually that CO2 is going to make its way to the lungs and we're going to breathe it out into the atmosphere. We're going to get rid of it. That's the whole point of this, is to get the oxygen from the lungs and deliver it to our organs, pick up the CO2 from our organs and put it back out into the atmosphere. So does that make sense? Okay, so we've just delivered oxygen to our tissues and we put the CO2 into the blood. So after this exchange happens, we're going to have a difference in partial pressures now in our deoxygenated blood. We've already delivered the oxygen. We picked up the CO2. And now on the other side, in our systemic veins, PO2 is now 40 because we just delivered oxygen. We started off with 100. Now we're down to 40 because we just delivered that oxygen. And would you expect the PCO2 to be higher or lower than it was before? Higher, because we just picked up that CO2. So now PCO2 is 45 millimeters of mercury when it was 40 over here. So does that make sense? So that's in our systemic veins after we've already delivered the oxygen to the tissues and we picked up their CO2. So now those systemic veins come back and return that blood through the vena cava to the right atrium, right ventricle, out the pulmonary semilunar valve to the pulmonary trunk and pulmonary arteries. During that whole time, did gas exchange again? No. So our PO2 and PCO2 are going to be the same for those pulmonary arteries. PO2 is still going to be 40 millimeters of mercury. PCO2 is still going to be 45 millimeters of mercury. And then that we are going to exchange with the inspired air again. So our deoxygenated blood is going to come to the lungs. The inspired air that we brought in from the atmosphere is going to come into our lungs. And then we're going to exchange gases again and be back to our oxygenated blood again. And we just go in this circle of delivering oxygen nutrients to our tissues and then picking up more oxygen from the lungs and dropping off the CO2. And we go in this circle all the time. One thing you probably heard from me and from other people is to never rely on color when talking about arteries and veins or talking about like tissue types. This is the one time that you can count on color. Anytime that you see a red vessel, you know that that's oxygenated blood. Oxygenated blood will always have a PO2 of 100 and a PCO2 of 40. Always. Anytime you see a blue vessel, that means that it is deoxygenated blood, and the PO2 will always be 40, and the PCO2 will always be 45. So one thing really quickly before I get to your question, Lacey, on a practical, I don't have any vessel boards out right now, but we're gonna have vessel boards out. You're not gonna have to name the vessels anymore, but you're gonna have to give PO2 and PCO2. Could be this model here. If I have this red vessel tag here and I ask you for the PO2, it's going to be 100. If I have this blue vessel tag here and I ask you for the PO2, it's gonna be 40. Okay? I can ask you on here, I can ask you on the heart, I can ask you on Slice Man, I can ask you on the board vessel model, but the thing will always be true. If it's red, it's oxygenated, PO2 will always be 100 and PCO2 will always be 40. If the vessel is blue, it is deoxygenated and it will always be 40 and 45. The things that are going to be a little different that you have to memorize is that for our inspired air, incoming air from the atmosphere will be 160 for oxygen and 0 or 0.3 for CO2. The other different one is going to be the alveolar sacs. So if I pointed to one of these sacs and asked you PO2 would be 104. So if it's at the top right hand corner, alveoli of the lungs, that'll be 104, and the PCO2 will be 40. So you have to memorize those sets of partial pressures throughout that cycle. Any questions about that?
So the pulmonary arteries, they're also at the 100?
Pulmonary arteries are going away from the heart towards the lungs, so they have not picked up oxygen yet. So they are deoxygenated and should be 40 and 45. Any questions on that? I know it's a lot. We're going to start right there again on Wednesday and talk through that whole pathway again on Wednesday, and then obviously add to it as well. But we'll start off and we'll do a review of that again. But that's going to be a big part of your next project flow exam. There's going to be lots of partial pressures throughout the stations. Any questions? Yes.
Is there any explanation for why the difference between the CO2 and the vessel going to the tissues is not that much different from the pressure in the tissue?
I think it's more because oxygen takes up much more space than the CO2 does. So when we have differences, you don't see it as big of a difference, and there's not as much CO2 moving as we have oxygen moving. Because you'll notice remember when there's a greater difference in concentration or gradients, then things end up moving faster. So we have a big difference in oxygen, 140. So you're going to have a big rush of oxygen into those tissues, which is why you see such a big drop. But then the difference between CO2 and the blood and the tissue is very small. So it's just 40 and 45. So that's going to be a very slow movement into the tissues, which is why into the blood, which is why you don't see a big difference. So it's just because there's not a great difference to start with. So the CO2 doesn't move as much as with the great difference in oxygen. You're going to see a lot of oxygen move. Does that make sense? Okay. Yeah.
So basically the systemic arteries are dropping off some of that oxygen into tissues, and some of that CO2 that's already in the tissues leaves and goes to the systemic veins, and then some of that oxygen that came from the systemic arteries are also going through the systemic veins to carry back.
Yes, because we're not going to completely dump all the oxygen from our oxygenated blood into the tissues. Just however much can be exchanged during that time it's in the capillary bed, and then whatever's left is still in the veins.
So it's basically like dumping and kind of like picking up.
Yeah.
Because the pressure of.
Yeah. So we're dumping off the oxygen that the tissues need, and we're picking up their waste. CO2 is a waste product that we don't want building up in our organs. So then we pick it up and then we breathe it out into the atmosphere.
So O2 causes the waste of CO2?
No, not necessarily. There's different metabolic processes that create CO2, but it's a waste product that isn't used.
And then we also breathe in CO2 as well, right?
We very, very little. 0.3 millimeters, very little. We don't really need it. Yeah.
So that's at resting, right? That's the
All these numbers are at rest. All these numbers are at
So
rest.
if we were to, let's say, exercise, the numbers would change, right?
The numbers would change. This 40 would be a lot less because we'd be using less oxygen. So then the movement would also happen a lot faster. So all the numbers are going to be a little bit different. And then the CO2 will be higher because you'll be working more and building up more waste. So yeah, those numbers will be different, but that's at rest. What I will test you on will be at rest. Any questions? All right, so we have about 30 minutes to review lab. And that would just be like you going through the models and refreshing